Hello everyone, my name is Rachel Resmer and today I will be presenting to you my quality improvement project entitled Evaluating St. Joseph Mercy Ann Arbor's Diagnostic Criteria for Gestational Diabetes. I have no financial disclosures. Gestational diabetes is an increasingly common medical complication in pregnancy. It affects approximately 6 to 8% of all pregnancies in the United States, and it carries adverse health outcomes for both mothers and their babies, including increased risk for cesarean delivery, fetal macrosomia, neonatal hypoglycemia, shoulder dystocia, and birth trauma. Treating gestational diabetes does reduce the incidence of these negative outcomes. However, the diagnosis of gestational diabetes is and has been controversial. There are multiple systems in place to diagnose, and it is controversial in terms of which of these to use, and there is insufficient data to support one over the other. The American College of Obstetrics and Gynecology recommends a two-step approach of diagnosing gestational diabetes. After an elevated 1-hour glucose tolerance test, gestational diabetes is diagnosed only after 2 abnormal values on a 3-hour glucose tolerance test. This was outlined in their practice bulletin. In the same practice bulletin, in reference to those women who obtain 1 abnormal value on a 3-hour glucose tolerance test, ACOG does specify that further research is needed to look at this population of women to determine if they are at increased risk of adverse outcomes compared to the general population and to determine if they would benefit from treatment. There have been limited studies looking at this population. Our obstetrics department initiates the gestational diabetes diagnosis and treatment protocol for women with 1 or more abnormal value on a 3-hour glucose tolerance test. The aim of my project is to compare the fetal and maternal implications of diagnosing gestational diabetes based on 1 rather than 2 abnormal values of a 3-hour glucose tolerance test. In other words, do we overdiagnose gestational diabetes, or do we prevent adverse outcomes of those who would otherwise not be diagnosed with gestational diabetes? This was a retrospective chart review of all women diagnosed with gestational diabetes between 2015 and 2018 within our system. We excluded women with pre-gestational diabetes and those diagnosed based on an abnormal 1-hour glucose tolerance test. Patients were stratified into 2 groups, the first being traditional diagnosis, those diagnosed based on 2 or more abnormal values on the 3-hour glucose tolerance test, and our more strict diagnosis of being diagnosed based on 1 abnormal value. Our primary outcome was the proportion of women who required medical management of their gestational diabetes. We also looked at secondary outcomes, including the maternal and neonatal outcomes, as you see outlined here. Parametric and non-parametric statistical methods were used where applicable. Our population of women consisted of 974 that were eligible for analysis. After excluding multiple gestations and those who transferred care during their pregnancy, we had 919 that were eligible. 461 of these women were diagnosed based on a single abnormal value, and 458 were diagnosed based on 2 abnormal values. There were no statistically significant differences in maternal demographics between the groups. The racial distribution mirrored that of Washtenaw County, which is what we would expect. In this analysis, 51% versus 45% of women required medical management of their gestational diabetes in the traditional versus the St. Joe's criteria of diagnosis. This difference was not statistically significant, indicating that women with our diagnosis are just as likely to require medical management as women diagnosed after having 2 abnormal values. Furthermore, there was no difference in the type of medication required for glucose control between the 2 groups. For our secondary outcomes, there was no difference in gestational age, birth weight, or risk for cesarean delivery between the 2 groups. In particular, the rate of cesarean delivery and the birth weight were almost identical between groups. The neonatal outcomes evaluated also were not statistically significant between groups. In conclusion, these compared with the ACOG diagnostic criteria, the diagnosis of gestational diabetes based on only 1 abnormal value on a 3-hour glucose tolerance test requires the same proportion of pharmacotherapy, for management of the gestational diabetes, has similar pregnancy outcomes, and has similar newborn outcomes. These findings support our continued diagnosis of gestational diabetes based on an isolated elevation on a 3-hour glucose tolerance test. Also, of note, in our population, the use of the ACOG criteria would have failed to identify almost half of the women who ultimately required medical management of their gestational diabetes, which we know treating gestational diabetes can decrease the incidence of adverse outcomes. Our data support further prospective studies to justify changing national gestational diabetes diagnostic criteria. Special thanks to Dr. Green and Dr. Mowers for helping this project. And here are my references. Thank you for your attention today.